All right. So I begin today's class with the diploma paper number 2, and let's now discuss the questions. Question number 1. See, this is a recall, guys. They've not yet put anything official on the website, the DNB website. So I'm just discussing the question answers as per the recall by my students. All right. So whenever you will have the final, the paper kept there, then I'll have to redo this whole thing. All right. So that a very, very big time investment for me. But anyways, let's start. So the first question that they gave was investigation in normal ANC. All right. So all of you there in the class, right? You can write down week-wise how these people, how is the investigations done week-wise in a normal ANC case. So what do you do in the first trimester? All of you know it's a MBBS level question, okay? So what do you do in the first trimester? You go in for a basic management or a basic routine test, like you go for a UPT, or if it's already done, then maybe an 18 ultrasound, okay? 7 to 8 weeks in which you just see the, the CRL, the fetal heart rate, the calculated estimated gestational age according to that particular ultrasound, whether it's a single fetus or double fetus. If it's double, then what is the presentation, right? All these things you start seeing from 7 to 8 weeks onwards. Then the baseline investigations, the blood investigations, okay? That was the major modality. And now the CBC, grouping, RBS, routine, urine routine, PFTs, and viral screening, right? Now this is optional. Okay, but you go in for a combined first trimester screening mostly, in which you combine the NTNB, the single ultrasound with the dual marker. And then, of course, they also compute the maternal age. And this is how you get the integrated marker of the first trimester screening, correct? What happens in the second trimester? Okay. Are you answering, guys? Okay. All right. Yeah. So second trimester, what do? You start with the quadruple test is there. Level 2 anomaly scan is there. Very, very important. Then every time you come, you do, yes, of course, for all Indian population, we are a high risk. So a repeat OGTT is there, or the first time OGTT is there. Repeat CBC is there. And then maybe a urine routine is a repeat. You do it every trimester. All right. You do the thyroid test also every trimester. Fetal echocardiography, yes, optional. Then third trimester, what do? You go on for, if there is a, the patient is A negative, B negative, then in that case, you'll have to go for a anti-D at this point in time if the ICT is negative. Then growth scans going on. And we are very, very particular with the growth scans now because the third trimester, right? Certain blood tests are repeated, like what I just told you, urine routine is repeated, Doppler ultrasound if it is indicated, and a repeat ultrasound at 36 weeks if indicated biophysical profile. So these are couple of tests. They said investigation and normal ANC. So investigation and normal ANC we've already spoken about. Now, next question was management of HIV in pregnancy. So I have taken the latest NACO guidelines. Okay, I don't know how many of you remember the case discussion we had, but in that case discussion, I took the RCOG guidelines. Okay, which I feel is not right because most of you have read the NACO guidelines, which is why I have taken this answer from the latest NACO guidelines, and here it is. So whenever a management is asked, right? So you start right from the history, the history of the patient and the examination of the patient. But this is an HIV positive patient, right? So there is no history in this except for the fact that when did she got to know that when did she got to know that she's HIV positive? Is she at high risk? Was she a high risk candidate? Does she know how and when she got it? Whether she's been monitored and she's been taking medicines or not? Is she on ART? If yes, how long? What are the latest parameters of CD4? What is the HIV, viral load? So all these things are very, very important. And you need to know this, right? Now, these are the history, of course. How will you manage this patient in pregnancy? So she is pregnant, okay? So we are not talking about the preconceptional counseling that you can just forego. Antenatally, you have to make sure. One thing which I want to tell you definitely over here. Okay, when it comes, I'll let you know. Yeah. So HIV, first of all, Antenatal care, may you have to talk about HIV screening is recommended as part of routine. So you know that she's HIV positive, but you will still go ahead and do HIV confirmatory test. Not only that, you'll get to know her CD4 cell count and viral load testing. And then you'll have to go in for a screening for co-infections also. There are many co-infections along with HIV. What are they? Hepatitis B, usually coexistent. TB, usually coexistent. Hepatitis C, coexistent. Syphilis, all the STDs, they're associated. So amongst the STDs, you have actually many. Herpes is also there, HPV is also there, but we talk about hepatitis B, C, syphilis, and tuberculosis. Tuberculosis, of course, is separate. Viral load testing, CD4 cell count, and an involvement of multidisciplinary team. Yes, this is what I wanted to tell you. NACO recommends that all HIV positive pregnant women should be initiated on lifelong ART regardless of CD4 cell count or the clinical stage. Goal is to suppress the viral load to undetectable levels, ideally by the time of delivery. And the preferred regimen is, I call it TEL. Okay, I call the preferred regimen TEL. It includes tenofovir, efavirenz, and lamivudine. Okay, all right. Now, monitoring during pregnancy, how do we do that? We do it with the help of viral load testing. We ask the patient whether she's adherent with the instructions, and nutrition support is just optional. Okay. How do we plan the delivery? So just imagine how are we, taking you from step to step. I'm talking about antenatal counseling and antenatal care right now, isn't it? Monitoring during pregnancy, very, very important. How do you monitor the CD4 cell counts? It's very, very essential. So do you do it every 3 months, correct? And frequent sessions to support ART adherence is equally important. They are very critical. Then delivery planning. Well, vaginal delivery is recommended with a viral load of less than 1,000 copies. Yes or no? Yes or no, guys? Are you? Everyone is awake or they're sleeping? Well, ma'am is going to speak and we will listen, huh? Is it like that, guys? All right. So what do we do in vaginal delivery? We recommend the women with a viral load of less than 1,000 copies per ml. The vaginal delivery, and for anything more than that, we recommend the cesarean section, which is very different from the RCOG guidelines. They say less than 50. They allow vaginal, otherwise it. Now, intrapartum care, you have to continue ART. You have to avoid any invasive procedure. That is also true with the intrapartum care and even antenatally as well. So intrapartum, yes, avoidance of any invasive procedures and ART continuation, and strict fetal heart rate monitoring along with vitals monitoring. Postpartum care, of course, you have to continue ART, which is very important indefinitely as a part of lifelong treatment, viral load monitoring there as well, and counseling for safe contraception methods. If you've not written these points, guys, your answer is incomplete. So this is what I tell you. And then comes the infant care. Postpartum, you don't have to just do the mother's care, but also the infant care. How do you do that? The ART prophylaxis in neonate as well. Now listen to this very closely. If the mother has been taking prophylactic ART, okay, she's very well controlled, and you know this, that she's very well controlled. Nevirapine alone is going to suffice. Suppose you do not know the ART status of the mother, or she's not very well controlled on ART, then in that case she needs mixed. She needs zidovudine and nevirapine both. I mean, the baby needs nevirapine and zidovudine both postnatally. Rest of the care, of course, the pediatrician is going to see the dose, the frequency, and everything, the toxicity management, the CD4 cell count. All these things are going to be seen by the neonatologist, but you should just know that if the mother is high risk, then the baby needs, or the infant it needs both nevirapine and zidovudine, right? Now, HIV testing. Infants should undergo early infant diagnosis at 6 weeks using DNA PCR. So again, two things are very important. You are giving the ART, what ART to give, whether the ART is being adhered to or not. And the second thing, what is the HIV status currently on ART? So that has to be routinely monitored. So early infant diagnosis at 6 weeks, okay, using DNA PCR, that is there. And then repeat testing at 18 months. In India, we are a low resource country. So this is going to be our, otherwise, according to RCOG, they do it at, I'll tell you. This is a separate protocol for breastfeeding and non-breastfeeding mothers, because HIV is the only condition in which breastfeeding is actually discouraged. So if the mother really wants to do breastfeeding, then the protocol is separate for the infant testing. You have to test it more often. And if the mother is not giving breastfeeding, in that case, or the fetus is called for HIV testing very often, right? So this is going to be the protocol according to RCOG, but this is the NACO guidelines. They say once it early infant testing is 6 weeks, and then repeat at 18 weeks. That's it. And infant feeding, see, The NACO guidelines recommend exclusive breastfeeding for the 6 months. Okay. Provided the mother is adherent to ART and has a suppressed viral load, breastfeeding should be stopped abruptly at 6 months to minimize mixed feeding, which can increase the risk of HIV transmission. If the mother's viral load is detectable or ART adherence is poor, formula feeding should be considered. See, so it's very, very important what the mother is, going through, and accordingly we'll give the formula of breastfeeding. Correct? And then long-term follow-up in the exact same adherence to the ART HIV testing. That's it.